Today we'll discuss something very interesting yet confusing for many of the ICU doctors. We'll clarify that confusion today. That is MIC and breakpoint. What is MIC? This minimum inhibitory concentration. This is the lowest concentration of an antibiotic cause visible growth prevention. That is in vitro, in the lab, not inside the human body. It does not say anything that it will be effective inside the patient's body at the infection site, right? That you have to understand. For that, so many things has to be taken care of that I will discuss. Now, for example, let's say we check ceftriaxone sensitivity for E. coli via broth dilution, right? So we have 4 broths. This is drug concentration 0.5 microgram per ml. This is 1 microgram per ml. This is 2 microgram per ml. This is 4 microgram per ml. Now we have 3 patients. Patient 1, E. coli stops growing at 0.5 microgram per ml. So this patient is MIC 0.5 microgram. Patient 2, E. coli stop growing at 2 microgram per ml. So this patient is MIC 2 microgram per ml. Patient 3, the E. coli stops growing at 4 microgram per ml. So this patient is MIC 4 microgram per ml. But then with these MIC, what to do? Whether we need to use ceftriaxone for these patients or not, who will give us that instruction? For that, we need something we call breakpoint. What is breakpoint? Breakpoint is cutoff MIC. This is the international standard, right? Usually it is set by authorities like CLSI EUCAST, WHO, right? What does it mean is, what they do, they take account the current epidemiology. And they select a particular MIC below which the drug will be called sensitive to the organism, right? Around it, around the MIC, it will be called intermediate, and above it, it will be called resistant. So intermediate does not mean half sensitive or half resistant, right? So sensitive means the drug will work at standard doses for the microorganism. Resistant means the drug won't act even if given at a higher dose for the said organism. Intermediate means the drug may work if we increase the dose of the drug, if we give the drug in a prolonged infusion, if we increase the exposure time. So many things are there. So intermediate is not resistant, it can be susceptible. It depends upon how we give it and where we give it, right? Resistant means it's unlikely to work even at higher level, right? For example, let's say the CLSI set cutoff MIC for ceftriaxone is 0.5 microgram per ml. This is all indicative. These are not true values. This is for explanation. I am giving examples, right? So then, in in patient 1 only, the drug will be sensitive. This will be resistant. This will be resistant because this is more than the MIC value. So according to class C, so taking account both MIC and breakpoint, we find that the patient 1 will be susceptible to ceftriaxone. You can give the drug there, not patient 2 and patient 3. So based on MIC only, you cannot prescribe a drug. So we have to take into account two things. One is microbiology. They will give the MIC value, class C, EUCAST or your WHO, they will give the breakpoint. Now as a clinician, we have both the data and we will try to tailor these data into PK/PD of the drug, site of infection, clinical condition of the patient, everything, then take a decision. This is very, very important, right? For example, a drug may be susceptible to ceftriaxone and to meropenem. But if the patient is stable, you can give ceftriaxone. If the patient is in shock, you have to give meropenem. You have to go broad as possible. Now we have a peculiar situation. Let's say we have a patient who is having urinary tract infection with Pseudomonas, right? And the Pseudomonas sensitivity to pipzo, the MIC, is 1 microgram per ml, and meropenem also MIC 1 microgram per ml. So which one to use? We'll say, sir, pipzo is a lesser broader spectrum antibiotic, patient is clinically stable, so we'll use pipzo. But is it so? No. Even so, we cannot choose a drug based on the MIC alone. We have to see the breakpoint. If it's the breakpoint, pipzo breakpoint is 16, meropenem breakpoint is 2. So the pipzo MIC 1 is very, very far away from the breakpoint, and the meropenem MIC is nearing the breakpoint. The ratio for pipzo is this called breakpoint MIC is to breakpoint ratio is 1 by 16 for pipzo and 1 by 2 for mero. The smaller the number, the smaller the number, the far away the antibiotic is from the breakpoint, the more susceptible is the antibiotic, right? So here we will use pipzo, even if both have MIC 1. Do you understand my point? So we have to take into consideration both MIC and breakpoint. Also, the MIC and breakpoint ratio. The drug who has a MIC far away from the breakpoint, or the MIC to breakpoint is very, very slow, that is preferable than to a drug who has a MIC that is nearing to the breakpoint with a higher MIC to breakpoint ratio, right? But at the end of the day, all of you should remember that it's a clinical decision, right? Here also, even though patient is equally sensitive to ceftriaxone, if the patient is in shock, then you cannot give ceftriaxone. You have to give a higher antibiotic. Similarly, here also, if you see pipzo is sensitive, but clinically patient is worsening in shock, so you have to give a higher antibiotic, right? So clinical condition is very, very important. Second is you have to see for the PK/PD. For example, nitrofurantoin in the blood may have a lesser MIC, but it works well in the urine. That you have to consider. For example, tigecycline, MIC will be less in the blood, but it will work in the tissue level. So PK/PD, site of infection, all these things we have to consider in the patient, right? Also, after we choose antibiotic, whether we have to give it in a prolonged infusion or you have to increase the exposure time, what is the PK/PD, is it time dependent, concentration dependent. So MIC and breakpoint only guide you, but as a clinician you have to take the decision taking everything together, right? Thank you very much.